The following podcast is part of a certified educational activity titled A Joint Effort to Improve Care in Tenosynovial Giant Cell Tumors, applying a collaborative approach when integrating targeted therapies in practice. Access the entire activity and complete the post-test at peerview.com/UCG860. Downloadable slides and practice aids are also available.
Hi, everyone. We're going to get started. My name is Sydney Stern. I am the director of TGCT Support. No shock, I am not Bill Tapp. You will have to wait a few minutes and you'll hear from him. So I'm going to go through some of the TGCT Support resources, which are often pivotal to patients finding providers. So to give you a background for those that are unfamiliar with TGCT Support, the Life Raft Group is a group renowned for its interest in GIST, or gastrointestinal stromal tumors. They went into a Facebook group that's known for TGCT. At the time, it was PVNS, and they asked a simple question: what would you change about your diet to make medication more effective? And I gave a technical answer. I have a pharmacokinetics background, and what they found was a relationship with the community that could answer some of these questions that were much needed in this space, and that could help facilitate drug recruitment for trials as well as information. And so we made TGCT Support in December of 2019. We have numerous resources, including virtual TGCT support groups, as well as virtual tumor boards, where if there's a patient that has a particularly interesting phenotype that may be benefit from more experienced providers or other collaborative efforts, we facilitate that. We have a mentorship program for patients directly to receive mentorship from other patients that have lived experience and through the process much longer. We have TGCT Days of Learning, where some of these speakers have spoken at or will speak at some point, hopefully. And those allow patients and providers to come together in a unique way to facilitate learning in a bidirectional way. We also have educational programs that come through our website, social media campaigns, educational material, and curated webinars, which provide empowering information for both providers and patients to have the most updated form of information in a rapidly changing field. We have a specialist list. Some of you are on it. And that is the holy grail for patients to determine who they will go to. And that's often validated and vetted through a process that we have in a survey fashion. Which you will hear on Saturday, are part of research within TGCT and provide a large registry, the largest registry currently, which help us collaborate with real-world evidence and answer questions that you may have. We have a patient registry, as I said, which we conduct. We have over 1,000 patients with diffuse TGCT globally in that registry, so it's the largest one. It now encompasses 48 countries, and we look at patient-reported outcomes as well as demographics. Any question you may have, we probably asked it, so we're always welcome collaboration and a collaborative effort amongst all of us, which is very common in sarcoma. And lastly, we facilitate advocacy. Often patients are unable to get treatment. There may be insurance issues, there may be health equity issues or health authority issues, depending on the country, and we play a pivotal role in that. We have multiple resources as well as best practices we created. We collaborated with SPAN to come up with a consensus guideline that is used from 50 experts to treat patients. We took that information, we made it lay language in 6 languages as well for patients. We're also publishing data currently, as well as we have a CTOS presentation, which is on Saturday at 4:30. So please, we are the dessert of CTOS, if you may say, so please attend. Some information regarding our patient program. Currently, we have 86% within our registry or within our program that's patients and 14% caregivers. Of the patients that attend the support groups within a year period, we have 519 patients that have attended. We have 250 patient pairs within the registry or within the program that are in this mentorship program. We have 129 TGCT volunteers, and we have a large funding effort as well. Some of the patient conferences we have pictures here. We often get asked, can you truly have enough patients for a conference? And wherever we go, we will bring patients. And so these are offered various times of the year, hopefully twice a year in places all over the world. So we did one in Rome, currently did one recently in Colorado. And so, as I said, currently we have patients from 48 countries, with the top ones in the US, UK, Australia, Canada, and Germany. No surprise as well. what I hope sinks in from this is that we're pivotal and we're part of this journey as well. And we have data that suggests patients receive information predominantly from us. So when you look at where patients receive information regarding any treatment option, all modalities, almost patients say that they receive information from TGCT support in similar quantities or proportions to their providers. And then for clinical trials, we reign on clinical trials. Majority of patients receive all their information on clinical trials related to us. So out of 990 surveyed patients, we are the predominant force, and we love collaborating to have more information. Similarly, I talked about that registry, and you'll hear more about that on Saturday. Our current projects are to understand patient experience from their symptom onset and how they make decisions in treatment. With more modalities and more treatments in the space, that's particularly going to become a curiosity for many of you. Lastly, we also are trying to understand the journey from presentation of pediatric patients. We have a large pediatric population as well within our registry, and to understand the differences in health system, including the outcomes based off socioeconomic status. And we do have enough data to compare different health sectors. Our overall objective of this registry is to add structured to an unstructured world, is to create quantifiable natural history with structured questions that engage patients at all levels of the disease, with an overall objective of honoring patients' lived experience while requiring and fulfilling the real world evidence requirements that make it science. And so this is what our registry looks like. So our call to action, it's timely. Our community thrives on this collaboration like many sarcomas. We facilitate tumor boards. We have the registry data. We refer patients to our resources, which you can be part of. We also refer patients often to providers. And we were just talking about how many of these providers receive patients directly from us. And we're hoping to develop a tissue bank that allows a repository for more research in this space. So you can contact me at ssstern at tgctsupport.org for more information, and it would be great for further discussion. Thank you for having me, and I will turn it over to the main event.
So I'd like to welcome everyone for coming today. My name is Bill Tapp. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, and I appreciate you spending part of your evening with us. I do want to thank Sydney. For those of you who do not know Sydney, Sydney is a consummate professional, and I don't think I've have a patient that hasn't been in touch with her. And just the tireless resource that she is for TGCT is truly amazing. So I'd like to thank TGCT Support, Sydney, and the Life Raft Group because it really is such a tremendous resource for all of our patients. So I really appreciate that. And I'd again like to welcome all of you here. Tonight's CME uh, lecture or hopefully interactive session is a joint effort. And I like the word joint there to improve care in tenosynovial giant cell tumors, applying a collaborative approach when integrating targeted therapies in practice. So I'm one of the panelists tonight, but I'm really fortunate to also have Nicholas Bernthal here and Emanuela Palmarini. So, what are our goals today? Well, our goal is to enhance your knowledge of the underlying biology of TGCT, assessing for recurrence risk and the rationale for the use of targeted therapies. We will hopefully be able to improve understanding of the latest clinical evidence supporting the integration of CSF1R inhibitors for the management of TGCT. We want to equip you with the strategies to formulate a team-based, personalized treatment plan based on current evidence of CSF1R inhibitors, guideline updates, and patient-specific needs. But a lot of it is also the dialogue amongst people here and the experts on the stage, particularly orthopedic oncologist, because it really is this multidisciplinary approach. And so it's to provide guidance on that multidisciplinary strategy to address the intricacies and care with targeted agents, including adverse events management, care coordination, and enhancing patient quality of life and experience throughout care. So I'm just going to give a brief introduction to TGCT. I know this is CTOS and probably something that we don't need to go into a lot of great detail, but hopefully it can just bring everyone to the same plane. So a new puzzle addressing challenges and unmet needs in tenosynovial giant cell tumor. So we all know tenosynovial giant cell tumor is a locally aggressive inflammatory neoplasm occurring mainly in the synovium of joints, bursa, or tendon sheaths. And it had different names in the past. There was giant cell tumor of the tendon sheaths, pigmented villonodular synovitis. We now all refer to them as tenosynovial giant cell tumor. And for some of our patients who have been dealing with this for a long period of time, it's a little bit of an adjustment because we often talk about TGCT in the clinic when they're thinking of PVNS. So we try to keep that in mind when we're communicating. There's always two types that we think about. There's the localized or the nodular. I don't think localized is the great word because both of these can be localized to one joint, but localized or nodular, and these tend to be small. They're single masses. They're well circumscribed and encapsulated, and a lot of times they're cured by surgery alone. So it's not generally the diseases that we talk about when we think about multidisciplinary care and the use of CSF1R inhibitors. That's more of the diffuse type, which are often large. They're very infiltrative within the joint. They can be very destructive and locally aggressive. The majority of the cases that we see, about 90% of them, are localized TGCT, and it's estimated to have an incidence of about 15,000 cases in the United States each year. I think this is a tough estimation because we're really just learning about the disease. The diffuse type is probably about 10% of the TGCT cases, so maybe about 4 per million person years, and about 1,500 new cases. Again, this is generally something that affects a single joint with an individual. There's a preponderance for some of the larger joints like the knee, the hip, but you can see it with any joint in the body, including within the spine and the jaw. So you always have to be aware for it. Locally aggressive tends to affect younger patients. Often, median age is about 45. It's not something that threatens an individual's life, but can totally change the trajectory of their life. And that's why really thoughtful care is important for them. Really, there's a slight female preponderance of the disease. There are rare cases of metastatic TGCT and malignant TGCT, and that's a different variation of this disease, but exceedingly rare. Localized, as I mentioned, most people are cured with surgery, but the diffuse disease can often have higher recurrence rates at surgery, and it can be anywhere from about 40 to 60%. Predominantly, the tumor bulk that we see are inflammatory cells. The neoplastic clone is actually just a few cells within the tumor, but what happens when they express CSF1R, they recruit inflammatory cells to the joint, right? And that's the tumor bulk. And these are giant cells, macrophages, but mostly mononuclear cells. So that's the type of tumor that we're dealing with. And then the inflammation causes the sequelae in the joint. Really, the one slide that I think is important for me to look at here is just this frond-like invasive appearance within the joint. I remember one of the orthopedic surgeons that taught me this disease a long time ago always said it was like an operating in mud. You know, it was very difficult to clear the joint. Nick, I don't know if that's true, but that really just stuck in my mind of what the challenges of surgery are within this disease. So the diffuse type can be really destructive. Patients can develop pain, swelling. They can have large joint effusions. They can have decreased range of motions. And for some patients, the surgical resection can be really challenging and it can incur significant morbidity with the high recurrence rate. So not to speak for our surgical colleagues, but I'm not convinced that this is a very rewarding surgery for them. So, patient journey, just some brief points on this. You know, these are kind of theoretical timelines of what people go through before we had treatment. But this is often a disease that was misdiagnosed, often in younger people who developed pain, and because of that, they would often go to multiple physicians to try to get a diagnosis, and it was very unrewarding to them. And when finally they end up either in an orthopedics office or usually an orthopedic oncologist and the diagnosis is made, there is often the potential for multiple procedures that they can go through. I just want to highlight here that this slide says external beam radiation, but that's generally something we don't recommend these days because we have new therapies for patients. And what's happened with those therapies, it's allowed for a really nice multidisciplinary approach where not only do patients still need to be seen by their primary care doctors, sports medicines, and potentially physical therapists locally, but we like to also bring the patients into the mix of the orthopedic oncologist and the medical oncologist when they have really diffuse disease, so we can discuss with the patient and all together and part of the team about what is right for them, right? Including surgery, medical management, or continued expectant management and supportive care. And so we want to get into these nuances a little bit. And I'm really excited to introduce a longtime friend, Nicholas Bernthal, who's professor, chair, and executive medical director. And I want to say the Jeffrey Eckard Endowed Chair in Orthopedics. And hopefully Mark is in the audience tonight. But Dr. Eckert was someone who taught us all and just really a tremendous impact on all of our careers. So I'm glad you hold the chair. And I'm going to turn this over to Dr. Bernthal.
Thanks very much. Thanks, Bill. And yeah, it's a pleasure to be here. I just want to echo the sentiments before we get started about Sydney and the support group she's created. I think what's been amazing to kind of see this journey over the last decade or so is just to see how educated our patients are now walking in the door and the level of sophistication we can have in these conversations as new options come out. And that's in large part due to her and her group. So, moving forward, we're going to talk a little bit about diagnostic principles of TGCT and then the implications of challenging disease presentations. So, Dr. Tapp opened up and talked a little bit about TGCT and this diffuse type versus this nodular type, but just sort of grossly stepping back, we're going to talk about this collagen deposition, these subchondral bone erosions. And for those who are not orthopedic surgeons, how important this is in the disease. This means that this inflammatory milieu in the joint is actually eating away at the cartilage that we rely on to have good functioning joints. And that for us is sort of the mainstay. It's that common pathway downstream of inflammatory arthropathies. Grossly, patients often have repeat hemarthroses, so they have bleeds and swelling into their knee, and we'll talk about how they present clinically to that. As Dr. Tapp mentioned, usually a single joint disease, swelling, pain, decreased range of motion, and stiffness. I think the other thing that may not be on this list, but is really key when someone walks into our office to pick up TGCT versus other etiologies of synovitis, is TGCT patients almost always will come in and tell you that they have intermittent swelling that's unrelated to activity. If you really probe them, they say, I just wake up and some days are terrible and then some days are good. And a lot of the inflammatory arthropathies that we see that are non-TGCT driven have a much more consistent pattern than that. Um, MRI is sort of the core to how we diagnose TGCT. It is a soft tissue mass, and so we use X-rays or radiographs up front. We can often see those bony erosions if it is a significant disease burden. But the MRI is really the mainstay. There are patients for whom they can't get an MRI, and a CT you can use it to diagnose a soft tissue mass, but MRI is certainly more sensitive and specific. And this statement in here, which has been sort of dogma in TGCT, is that surgery is the standard of care. And then usually there's some now parentheses or hedge behind it. Hopefully, through the course of tonight, we'll talk a little bit about whether that really is the right approach and the approach we should, the framework from which we should enter things with these patients. Um, the synovium is the capsule of the joint, and the synovium's job is to make fluid and lubricate the joint. And in TGCT, these synovial villi are populated with macrophage, and there's huge quantities of hemosiderin in the synovium. And this gives us one of the tools that the radiologists have is called a gradient echo MRI. And this allows you to just with a software change, it can be on a 1.5 Tesla machine, it can be on a 3 Tesla machine. This is just the templating in the MRI to look for gradient echo. So oftentimes when TGCT is suspected, we will put a note into our radiologist to make sure they look for gradient echo MRI because it actually allows us to be quite a bit more specific diagnosing TGCT from other inflammatory arthropathies. The contrast can make the synovial thickening more conspicuous, but I don't think holds nearly the advantage that the gradient echo does in terms of diagnosis. These are nice pictures of TGCT, and they tell a lot of the story. And for those who aren't used to looking at MRIs, you have sort of two different sequences here: a T1 and a T2 formula here. So fluid is bright on this side, and you see one of the things we talk about in TGCT is that you have dark nodularity. This is actually tumor burden, and then you have bright fluid, very fluid heavy sequence here showing kind of inflammation. And I think one of the folks who likes to talk about this is always refers to this as TGCT has both an oma or a mass and an itis or an inflammation. And we have to kind of tease out which is which in terms of the symptoms, because often you can treat the oma without treating the itis or treat the itis without the oma. And you got to figure out what's bugging the patient. Here on the right on T1, you see how this just looks like one very enlarged mass. This is that example of gradient echo, and not to get into the details of radiology here. Suffice to say, this bottom image here is a gradient echo sequence, and you can see when you're measuring things, the nodule back here in the notch is actually quite large compared to what it is anatomically on a T1. And basically the hemosiderin gives you a haloing effect around it and allows us to see this. And that differential will allow the radiologist to be much more confident in a diagnosis of TGCT rather than a different etiology. So our colleagues in the Netherlands put together a nice paradigm in 2018 in surgical oncology that looked at TGCT MRIs and then went down the list to see what predicts who fails. How can we get a better sense of who is going to have recurrence-free survival versus those we're going to solve with surgery? And you see here, we have this paradigm at the top, which if, whether we like the terms or not, somehow we define this localized or sometimes called nodular subtype, and then on the other side is diffuse. And you see in localized disease, as you work down this algorithm here, you see that whether you have involvement of ligaments, muscle, tendon tissue, yes or no, you're still talking about surgery getting you to almost a 90% cure. This is really important. And I think part of our education and a lot of the education when we go out into this is educating general orthopedic surgeons and sports medicine doctors about the risk of operating on TGCT. And we'll talk about that in a minute. But we also have a job to educate the medical oncology community because there's a huge population out there that can be cured with a very straightforward surgery. And so, someone who happens to walk into the door of a medical oncologist with TGCT does not mean that they need medical therapy any more than walking into the door of a surgeon should mean you need surgery. If you look here on diffuse type, it's a very different story. So they defined as intra or extra-articular disease or both intra and extra-articular disease. And then as you look down, you start seeing these recurrence rates that are what we would call surgically depressing. When you start looking at recurrence rates of anything you do in an operating room and you're saying maybe I get 50% success, you probably shouldn't be doing that in an operating room. And so this is where we start really taking pause. So whether we call it 59% in this series and 36%, it's probably worse than this because this is only capturing the people who go on to get more MRIs to prove you didn't get it all out. So these are pretty humbling numbers in diffuse type. But this is, I think, actually a nice case example because we often talk about what the typical patient is. And if you ask a medical oncologist, like either of my colleagues on stage, their typical patient is different than mine in orthopedic oncology. And that's very different than typical who walks into a sports medicine doctor's office or a rheumatologist's office with this disease. But as far as I'm concerned, this is a key population, and let's talk a little bit about it. So this name given is Christina, 40-year-old female patient. There's an effusion in the knee with intermittent pain and swelling. And MRI here shows diffuse TGCT. Now, my bet, because we're going to take this supposition that this person has walked into a sports medicine doctor's office, is that they did not call it diffuse type TGCT. They probably said you have very severe synovitis. Look at that effusion, all of that bright colored fluid, and then these little nodules. This is synovitis, and I have a scope. I can solve your problem. And that is the usual discussion that happens when a patient walks in with something like this. We're going to talk about whether that's the right or wrong answer, but let's see where this goes. So, Christina now returns to the clinic 6 months later. She goes back to that same sports medicine doctor and says, "You said this was going to get better. I had surgery and I thought I was in the recovery phase and I felt like I was getting a little bit better and dealing with the post op stuff for 2, 4 weeks. And then at 6 weeks, I kind of had a little period where I was feeling a little bit better and I thought I was going to kick this thing. But then at 8 weeks, it started to get worse again. And now here I am 6 months later. I'm really unhappy. Now the new MRI comes and we see more effusion, right? There's more swelling, this bright area in here. And now these nodules, these diffuse nodules, are quite large inside the anterior aspect of the joint. Both, this is the kneecap, so this is the patella, so this is on the patellar side, and this is on the femoral side. But you see these nodules here. And you also now see there's disease. One of the problems is that when a scope goes into the knee, the way it works is that the surgeon pours fluid into the joint to make the joint larger so they have room to go around. Then you are literally taking a shaver that chops up the tumor and tries to suck it out. The problem is that when you've now put fluid all through the knee and you've shaved up a tumor, you can have tumor cells that show up in other parts of the knee. And so our previous cut may not have been comprehensive, but when we look at this MRI, we now have got a lot of disease behind the PCL here that's coming in the back of the knee. This is a much bigger challenge operationally to deal with than it was up front. The patient is upset. The surgeon doesn't know what to do and says, "I'm going to refer you to an orthopedic oncologist." And that patient is a patient we see all the time. And the fundamental problem here is that patient's expectations were totally not set correctly. That patient went in and was told it's a simple problem that a simple arthroscopy is going to solve. And there was no discussion about other options. Should we have an open surgery? Should we talk about systemic therapy? This is a disease that has a recurrence rate that's meaningful. Those discussions do not happen by and large in those original offices. And that leads to a patient who now arguably is worse off with disease in areas they did not have previously because they didn't get educated. So as we move forward, they've now come into an orthopedic oncology office. We've had a conversation. Hey, this is TGCT. It's diffuse type. It's recurrent TGCT. That's even more of a problem. And now we have to figure out, we're going to kind of hang tight for 3 months. And we're going to talk about this watch and wait strategy a little bit later, but we have to figure out what is the natural history of Christina's tumor, not what is the natural history of TGCT globally. Because some people have a very rapid, proliferating, growing type of biology, and some people have a very static, slow growing biology. And so back to the itis and OMA question, you could see Christina at 6 months, and we say, let's deal with the itis. Let's do icing your knee, compression wraps. Let's do physical therapy. Let's do NSAIDs. Let's do things that deal with inflammation. And let's watch the OMA. Let's make sure you actually have a growing tumor. Pretty reasonable approach. The problem is Christina seems to have a progressive disease. Now we've taken a 3 month new MRI. We see that there's worsening tumor burden, and now you start to see this. Do you see on the tibia here, this dark aspect down here is the bone? But now you see this erosion. So now she's starting to lose bone. There's some erosion that's gone through the cartilage. All of that inflammation has eroded down. So now we've got a problem. And I think here is really this key point that more than anything else that we can do, Christina wasn't offered a fair set of options up front here. And there's this recommendation here in green that really is important. And it's the one thing I think we found almost universal agreement on when we talk to the orthopedic surgery community is that the obligation is on us to educate patients up front about this disease process, about what their options are and what realistic expectations there are. If they know that there is a risk of this arthroscopy leading down this road and they choose that because they don't want systemic therapy, or they talk about open surgery and pros and cons, or they have these opportunities to have the discussion, then we all accept this can be a hard disease to treat, but they have to have that education. So when deciding on surgery versus observation, we talk about these multidisciplinary decisions, and we have to understand the TGCT for that patient's natural history. It really, I can't emphasize this enough. The top study that many in this room participated in, we followed 200 patients for 2 years, and two-thirds of them had very slow growing, if any growing, of their actual tumor. And so some people have very static disease tumor, and that's a population you may be more inclined to watch. We have to know the natural history. Key points on the bottom here, localized type still has a high potential to be cured by surgery. When we look through that MRI and we can draw a circle around it, we confidently say we're going to get it out. That may be the right approach. That's okay. We got to know what we're looking at. Observation may be appropriate for asymptomatic or more indolent disease. Finding those patients for whom the natural history is not progressive is really important, and understanding we can deal with the itis or inflammation sometimes, and we can render patients to be in a pretty good position without actually dealing with the underlying TGCT if it's not symptomatic. And then asymptomatic large masses may be observed, whereas smaller masses may require treatment. And this is a good take home point that we get obsessed about imaging. As medical oncologists, we're always talking about RECIST and used to watching tumors. As orthopedic surgeons, we jump into an MRI and it's all, can I get it out? And where's the vessel? And can I keep this safe? The thing is that a lot of people, when we look at their imaging before we walk in the room, we shoot about 50% on knowing how symptomatic. It's a coin flip. And you can look at imaging and have terrible imaging and walk in the room and the patient looks at you and says, I'm actually doing fine. And you can walk in with a tiny little nodule of TGCT with a lot of effusion around it, and you can have someone who's really hurting and needs intervention. I'm gonna wind down a little bit. I'm gonna talk about I'm presenting Emanuela's paper here, so it's a little bit interesting to present someone else's work who's standing next to you. But they did a very nice study in 2015 just looking at high risk subtypes. And so this was in the era before systemic therapy was available. And this was just taking the question, what is going to define who's going to do poorly with surgery? And, we can flip through this pretty quickly in terms of looking through the demographics, and more women than men, as we'd expect. There's sort of this tumor size distribution that's fairly typical, the knee, the preponderance in the knee. Um, and they had in this population, and frankly, this is really important. We talked about who is typical for someone. If you look at this list of authors, this is really well-known medical oncologists, sarcoma centers. So they're going to see a diffuse type that's more than two-thirds of the population compared to the localized type. Really important to know that out in the world, it's 10 to 1 the other direction, right? And so medical oncologists see a different type of disease than what is out in the world. But 2 to 1 diffuse type. Local recurrence rate here was listed as 28%. The mean time to relapse, 16 months. I think the real important message here is put nicely in red. When someone is a recurrer after surgery, going back and doing more surgery is going to lead to more recurrences. This does not take a advanced degree in anything to figure out, but it was really important for this study to demonstrate this, that these patients that we historically whittled away at, that we would just go in every 2 years and operate on, it's coming back. And you better have a good reason why you're continuing to do the same thing over and over again. The patients who have recurrences are more likely to have the next recurrence. If you look here, breaking down histology and size, really tumor characteristics were far more important in terms of high-risk subtypes than patient characteristics, obviously diffuse type being more, uh, um, but again, the localized type that's walking into a medical oncologist office is probably a skewed sample size. And this goes back to that same point that the new patients have sort of 77% here that it's curative, or there's, disease relapse free, whereas somebody who comes in on a relapse had 12% likelihood of resolving this with additional surgery. You can see here new diagnosis versus first recurrence. We're going to hammer this point home. And here, Massboom looked at a global multi-center study looking at high-risk subtypes. Similarly, we talk a little bit in the surgical community about whether it's better to do this through a scope or open. Everybody has their biases. This paper shows here on the right side that the results, at least for this retrospective review, were pretty similar. There's a very high recurrence rate no matter what you do surgically, and thinking you are that much better than everybody else in the world taking this disease out is a very ambitious view of oneself. Here again, they reiterate that same finding that new diagnoses versus recurrent disease. So recurrent disease continues to recur. So, in the era of multimodal therapy, standalone surgical resection can no longer be regarded as the only treatment for patients with diffuse type TGCT, and alternative or combined approaches should be considered. I think even this was stated in 2019, and I think this is a statement that we can even push further now with all of the data we have and the new options that are available to us. I think this is my last slide here, but this is sort of this roadmap. This is not meant to be definitive. This is a proposed roadmap that Emanuela and her co-authors put together, but I think a really nice concept looking down this, that the first branch point, one of the things I love about this roadmap is the first branch point is, are they symptomatic? It starts with the patient's symptoms, not with a finding that the physician has. It has, do we need to treat at all? That should always be number one. The next thing is, okay, if yes, now we're starting to look at what are the surgical, how morbid is it? How much am I going to hurt someone taking this out? And how much do I think I can get it out? We quickly get the neoadjuvant CSF1 inhibitors into the discussion. And for me, no patient goes to the operating room with me or our sports medicine colleagues or any of the orthopedic surgeons in our department or in our area without at least a discussion of what the options are out there. And then I will hand the microphone over to my dear friend.
So I will start again thanking Sydney. I want to tell you a story. So Sydney has been referring patient for all the time now. So when we have a rare tumor or any problem, we Google it, and now you will find TGC to support. And one patient of me came to me is a medical student, 23-year-old. His mom is a neurologist at one Bologna hospital. I work in Bologna. And then when they see to my outpatient, they say, okay, I came to resolve to an orthopedic surgeon. I had this problem on my hip. I was already in my operating list, but Sydney advised to come to you first. So I really think that the way that the network should work. And there's another case, is a 32-year-old male. As you can see from the MRI, the disease was really widely diffuse, I would say, with this posterior huge map. This is a MRI contrast median, but also in the anterior component and some edema. The patient reported some diagnosis back in 2016, and 2 years later, progression of the symptoms, BAS on a scale to 0 to 10 of 5. He is a bartender and he is unable to work. This is the story of many of these young people. So what we would do now, the story has changed since they discovered back in 1994 of this fusion. So in the past, we called pigmented villonodular synovitis, so inflammation, but it's not. It's a tumor, and this is a pathogenic fusion which confirms the tumor origin of this self. And this paper back in 2006 nicely describe this neoplastic and inflammatory cells autocrine loop. So this receptor it's able to activate the inflammatory cells to get into the close to the tumor, and then the tumor burden and the inflammatory changes are both synergic in creating the symptom, and this is very important to understand. And this is another paper showing that other fusion exists, CS1, VCAM, FN1, and CDA, H1, to show the heterogeneous of these diseases. And there are some mutations that are also associated with bad or good prognosis, like a CBL mutation. But the current guideline have changed since the introduction of new treatment strategies. Imatinib was the first described back in 2008 by Janice Bley, a case report showing a complete response, and then there were retrospective series, although the overall response rate was about 31%. Nilotinib was less effective, only 6% of partial response. And then we had the first registrative trial. It is a phase 3 controlled trial in advanced symptomatic TGCT, showing an overall response rate of 39% versus 0 in the placebo arm, and this drug made it to approval in United States. And this is a kinome on the right, showing how this treatment is most effective, because it's most specific for this kind of disease, and that's why it's able to elevate and importantly reduce the symptoms better. And in built up here is the same as per Brentel. I'm gonna present the data of built. In 2015, did this New England publication on the first series. There were 23%, 23 patients in this phase 1 study. And I like it that you notice all the stars. The stars in the bars, they are many, actually, are most of the patients, and it's never happened to us, medical oncologists. So I sure it's a very nice picture. And it's a racist partial response, the star. So by racist, partial response is defined by the reduction of more than 30%, and it is really an achievement. And so as you can see, 20%, 20 per patient at the response rate assessed, and those are in the bar. And since this experience, this placebo-controlled study was designed, inclusion criteria, and this is one of the most important thing, and because most of the patient can be observed, some surgically operated, but those where surgical resection is associated with potential for worsening of function or severe morbidity, they should not undergo surgery, and they might be eligible for study or treatment. Of course, for a clinical trial, you need measurable disease, 2 centimeters, but it's quite easy with this kind of tumors. So it's always challenging to propose a patient a randomized trial, but all this study had the crossover. So as you can see, after the first 24 weeks, all of the patient would receive active treatment with pexidartinib. And the study set also another important point, that in a benign tumor, not killing the patient, not giving metastasis, we don't only need response in terms of measurable disease. We don't have overall survival to assess likely. And so it's very important to assess all patient-reported outcomes and measure of quality of life. So you see in the bluish line on the bottom, all these very important parameters that need to be taken into account when describing this treatment, which is range of motion, changes, and other patient-reported outcomes along with MRI. All were assessed at 25 weeks. And this is very nice. It's called waterfall plot, and again, medical oncologists never see something like that. So this is the placebo. So it's interesting also because you can see that some patient had this is 0, the line, and then this is the size of the disease that it's reduced. So with the drug, all these patients had complete disappearance of the tumor and this all reduction. And all the crossover patients, so you can take the drug at the beginning or after 6 months, you're gonna respond. And RACIS as the limitation is monodimensional. So for this disease, tumor volume score is more accurate. And so as you can see by tumor volume score, most of the patient and partial response according to tumor volume score measurement, less than 50% reduction. And this is the comparison in between pexidartinib 61% patient and placebo arm. So the partial response is 25% versus 0, and the overall response by tumor volume score is 51%. So based on these results and this important difference, FDA approved pexidartinib in the United States for the treatment of TGCT associated with severe morbidity, and also, of course, not amenable to successful surgery. And this is the case presented by Dr. Stacchiotti from Istituto Nazionale of Tumori Milan. Of course, this is likely there is no diffuse TGCT of the end very frequently, but it gives us an idea of how sometimes this benign tumor is not. We started to call this locally malignant because with this disease, you see this picture of October 26. You can even use your hand, which is like a very basically important for survival. So the drug really work very well in this patient, which regain back our mobility and the use of his hand. Side effects, of course, occur, and pexidartinib, it's has several side effects. First, hair color changes that for a disease that mainly affect patient in their 30s is not non-important. So 67% of the patient had hair color change in this clinical trial. Fatigue, 1 out of 2%, but of course we have to focus in the liver toxicity because about 40% of the patient has transaminase increase, and what is most important is combined increase of bilirubin and transaminase. So as you can see in the placebo arm, none of the patient had, of course, side effects, but in pexidartinib arm, about 33% had the grade 3 transaminase increase or increase of bilirubin more than twice upper normal level. So the combination also of both occurred in 5% of the patient. This is clinically significant. And this combination of increase of bilirubin or transaminase or phosphatase alkaline, it's called mixed or cholestatic hepatotoxicity. And it's important to acknowledge because it might be life-changing. So this drug is now approved in the United States, but prescribers have to pass a test to be able to prescribe. So all the patients are safe, are in good hands. We are sure that the prescriber are well aware of this potential toxicity. So there are strategies to mitigate this risk. So REMS program, so this test for prescribers, but also dose reduction. I have a patient, 74-year-old, that has been on pexidartinib for 6 years now, and she's been on 1/4 of the prescribed dose, 200 milligram total, and the drug is still active, and she has no side effects. So that tough to us, especially outside clinical trial. So this exam should be tested regularly. And then the very good news is the improvement in range of motion and the patient-reported outcome. In this picture, you can see promise, so improvement, so the functional assessment. The placebo is the red area, and the pexidartinib show how the cumulative change with pexidartinib is significantly better. And of course, the stiffness with the pexidartinib is also reduced, and this happens very, very quickly during the treatment. So I want you to know that with Steph, we will discuss on all these on this trial, and in particular on the surgical history of the patient we treated within the Eleven trial, and I'll be there. So other strategies.
Thank you.
Yeah.
Thank you. So great job, Nick and Manuela. And I'll talk a little bit about emerging evidence and other CSF1R targeted therapies. The main one which we'll talk about is vimseltinib. So vimseltinib is an oral switch-controlled tyrosine kinase that selectively and potently inhibits CSF1R. So this is a kinome that shows the other kinases that are affected, and you can see the majority of what we see is CSF1R inhibition here. There was a phase 3 clinical trial that was mirrored to the Enliven study. And it's important, even though that we had access to pexidartinib in the United States, pexidartinib was not available in Europe and other countries. So it was still felt that a placebo-controlled study would be very important. So this is actually the MOTION study, which is again a pivotal phase 3 study. And it had very similar eligibility criteria that people needed to be greater than 18 years of age with a confirmed diagnosis of symptomatic TGCT, for which surgical resection would potentially cause worsening functional limitation or severe morbidity. So very advanced disease. Patients were allowed to have prior treatment with imatinib and nilotinib for this study. And again, there were two parts of the study. So in part one, eligible patients were randomized in a 2-to-1 fashion to get vimseltinib, which is actually dosed 30 milligrams twice weekly versus placebo. And randomization was stratified by geographical region the tumor location. So part one, just like in the MOTION study, lasted for 24 weeks. So the end of part one, patients could be unblinded. And if they were on vimseltinib, they can continue on to part two of the study, which is actually the long-term treatment phase. But if patients were on placebo, they could actually then get active vimseltinib. Again, as Emmanuel mentioned, the placebo is necessary to understand the natural history in the patient population, but patients didn't want to be kept on placebo for long periods of time. So the endpoint was actually going to be at that 25 weeks, which is the end of part one. And the primary endpoint was overall response rate by independent radiological review using RECIST version 1.1. And the study was powered to detect a 30% difference between treatment arms. And as was mentioned before, RECIST is not always the right way to measure these tumors because it's just a unidimensional measurement. And if you saw some of those pictures before, when you have anterior and posterior presentations of the disease, it's sometimes very hard to draw a line around them. So it's actually a really risky endpoint in some of these studies, but it is what was mandated by the regulatory bodies. So importantly, we needed to have a lot of key secondary endpoints, and one of them is the tumor volume score, which Manuela also spoke about, which is actually an extrapolation of the normal synovial space and then how much the TGCT was in excess of that. So it does give a volumetric measurement in which we can encompass the whole disease. What we've learned from that, it's probably more of an accurate measurement early on, but because these drugs work so well, resist actually catches up to that over time. But importantly, because we're developing drugs in a benign neoplastic process, tumor shrinkage is not necessarily the most important endpoint for a patient. It's nice to tell them that their tumor is shrinking, but what's more important is that they have symptomatic improvement. So we looked at this with subjective and objective measures, including range of motion, right? This was measured by goniometry testing. And then there were other patient reported outcomes, including a TGC specific promise physical function that was actually developed for the Enliven study early on. There was also changes in baseline and worst stiffness with a numeric rating score, and changes in baseline and health status with an EQ visual analog score for the patients. And then there was a brief pain inventory. So, 83 patients were randomized to vimseltinib and 40 patients were randomized to placebo. Again, this is a younger patient population with a median age of about 45, slight preponderance of women, as we often see. And the majority of patients had disease within the knee, although all joints were affected, right? So this was again, indicative of the incidence of the diseases that we see. This was a heavily pretreated group from a surgical standpoint. About two-thirds of patients in each arm had surgery, and about 20% of patients had prior treatment with imatinib and nilotinib. And here are the endpoints of the study when we look at, again, the primary endpoint, which is overall response rate at week 25. So a temporal hard endpoint for the study is that the overall response rate by RECIST was 40% for the vimseltinib group and 0% for placebo. And this was highly statistically significant, as you can imagine. The median duration of response was not yet met, right? Because patients are going to remain on treatment. And what we know is that the majority of patients, if you remain on treatment, you will not have progression, right? So you'll see the durable responses. When we look at the tumor volume score, so this, in essence, volumetric measurement, it was also highly statistically significant, with about 67% of patients having an overall response by tumor volume score on vimseltinib and 0% again for placebo, and median duration was also not yet met. Importantly is that all of the secondary endpoints, the patient-reported outcomes, were actually also statistically significantly improved for patients who were receiving vimseltinib, and this included active range of motion, with the PROMIS physical function scale, were stiffness, quality of life, and pain. So not only was the drug shrinking the tumor, but actually what we were seeing was improvements in quality of life, range of motion, pain, stiffness, what we really want to see when treating an individual. Now, kind of a complex slide, but there's 2 points that I wanna show here. One is that improvement in all of these endpoints happen pretty quickly. Because these are inflammatory conditions, when you start a strong CSF1R inhibitor, either pexidartinib or vimseltinib, what you can see is dramatic improvement with just a few weeks of taking drug, and importantly, that this is sustained. So you can see the difference is sustained as long as patients are on drug. The other take home point from this, which is really important, is that symptoms improve regardless of whether or not a patient actually achieved a RECIST response, right? Which is kind of a very arbitrary endpoint and difficult to measure. So you don't have to have dramatic shrinkage in a tumor to actually see clinical improvement in symptoms. And when we treat patients with strong CSF1R inhibitors, we don't care generally how much things change radiographically. It's nice to tell patients that the disease is shrinking away. What we want to know is how their symptoms are improving. So, really gauging why you are starting a drug with a person is really important because that helps you understand if you're truly helping them. And patients can often quantify the types of pain they have. Often the pain is due to, destruction of the joint and arthritic pain, which a drug can't help. But they'll often say things like, I want to be able to dance with my significant other. I want to be able to garden, right? And these are the things that you can begin to determine if the drug is helping, if you start to see improvement in them. Overall, vimseltinib were generally well tolerated. There was some periorbital edema, there was some hypertension that we saw, but most of the treatment emergent adverse events were grade 1 and grade 2. There were serum elevations in CPK, but these were not thought to be clinically relevant. And throughout the course of the study, they were actually no longer checked. But the treatment emergent adverse events that led to discontinuation was only 6% in participation. And there was no signs of cholestatic hepatotoxicity or drug-induced liver injury. And because this is a very specific CSF1R inhibitor and didn't target wild-type KIT, we didn't see white hair or hypopigmentation. And so I just do want to point out that Dr. Bernthal also will talk about some of the efficacy, safety, and patient-reported outcomes of vimseltinib in the MOTION study. And we were joking that I'm presenting a surgical abstract and Nick's presenting a medical abstract. So we should probably switch because neither of us wants to get questions from the audience. So if you're there, don't hammer us with questions. But the other thing is what led to the MOTION study was that there was actually a phase 1/2 trial, and there were several cohorts in TGCT specifically, right? And what we wanted to show is that one of the cohorts actually was a trial in which patients were allowed to get vimseltinib after they had promising anti-tumor activity on other drugs, including pexidartinib, imatinib, and nilotinib, all of which can be very active. And what we know about this disease, because it is a neoplastic process, the neoplastic clone is in the minority of the tumor and is probably not rapidly proliferating, we tend not to see resistance develop, right? So when you stop a drug and you watch a patient, if you need the drug again and you re-challenge, you almost always see responses. So it's not like the malignancies we treat where we often begin to see resistance develop. And this is just to point out in patients treated with prior tyrosine kinase inhibitors, you can see high response rates and long duration of treatment, right? So this is really important when we begin to think, how do we treat patients longitudinally? And we have some patients that once they get a great response, they never want to come off of drug. But more and more, we're kind of setting times to say, let's treat for a year, let's treat for, a period of time and then stop drug and see really how well you do, right? And at that point, if you start to see symptoms develop or progression where you need medical management again, and that's something that is always debated, you could talk about restarting inhibitor, you could talk about surgical interventions, right? But we have to think of this disease differently than we would a malignancy, right? Where if you start to see a recurrence, you treat immediately, but we don't want to treat radiographically. We want to treat patient symptoms and what's actually happening within the joint. And Andy Wagner tomorrow is also going to, or I don't Saturday, sorry, is also going to present some data regarding some of these other cohorts within the phase 2 study. So there's really wonderful resources with vimseltinib. There's really wonderful resources with pexidartinib. Again, TGC Support has really thought about how to use these drugs by talking with their patients, and they have a lot of really wonderful resources. So here's some QR codes in case you would like to see that. But there are a lot of drugs that are emerging, and I say that with a little grain of salt because the middle drug, amectuzumab, has also been around for as long as pexidartinib. And some of the original slides that Emanuela showed, not only did you see the kinome of pexidartinib, but you also saw some of the binding of amectuzumab. Amectuzumab is an antibody, right? So it's different than an oral inhibitor. It's an infusion. And it's often something that you can do for a period of time and stop and see long-term, durable responses with that. So we hope more and more drugs will come out so we have options for patients. Do you want to actually get an oral inhibitor? Do you want infusion? There's a company now actually making injectables of CSF1R inhibitors into the joint. Pimacotinib is another small molecule inhibitor that actually just had a phase 3 study, the Maneuver study, and I think they've had some press releases of the top line results, which actually look promising, right? So hopefully not only allowing drugs to be available in Europe and South America, but also Asia as well with some of these promising results that we're seeing. And also there is cabiralizumab as well. I'm not as familiar with it, but definitely by the name, it is another monoclonal antibody, right? So options for our patients, which are really important. So I'd like to go back to case two, which was Thomas's case, which Emanuela spoke about. So a 32-year-old with limited range of motion. And it's interesting because how often, do we say in our HPIs that this is a restaurant worker? And why is that important? Because that probably means that he's on his feet a lot, right? So if you have TGCT, that can affect quality of life. It can affect your ability to be employed. It can affect your ability to attend to your ADLs, right? So arthroscopic diagnosis, progression, and is unable to work because of decreased range of motion, right? So I think what I want to do is kind of bring this back to the panel because it's interesting. As a medical oncologist, we spend a lot of time trying to get a drug approved. But in this disease, we spend a lot of time saying, why should we not use that drug? And what else can we offer an individual so that we don't have to treat with medicines, right? And we heard from Dr. Bernthal that a surgeon, usually the first thing you think about with an MRI is, can I operate? But they also say, we shouldn't be operating. And Nick and I were talking the other day, and he said, I had 11 people with tenosynovial giant cell tumor in my clinic, and I didn't offer an operation to any of them, right? So really sitting down with the patient, understanding the importance of how the disease is affecting them and what are the treatment options for them, what are their goals of treatment, is the disease affecting the joint, destroying the joint? But what do we hope to do when we even think about surgery or medical management? So I'm going to start and maybe we'll send some questions. The first questions is, given the patient's functional limitations, what treatment options would you consider? Emanuela, would you start systemic therapy? Nick, would you offer surgery, multimodality approach? What would you do?
So this patient has a very large and diffuse disease. So it actually it was the all the way back. Our surgeon sent it to me. So we discussed it in a multidisciplinary discussion. So in the past, this patient would receive, and Nick, I think you can agree, posterior approach first, maybe because it was larger, and then second anterior approach. But at the time it was discussed, we had the trial. So what do you think, Nick?
Yeah, no, I think looking at this, if we go back to some of those rubrics and nomograms we saw early on, this is, clearly diffuse disease. There's intra-articular disease. And so you've got intra and extra-articular disease, even going back to the Massboom paper and others. I mean, this is a very low rate of success from surgery. So for me, this is unless the medical oncologists are saying there's a reason not to treat this patient, we would start with treatment. The only other just quick comment I'll make is that we always want to look at this MRI, and right here, fortunately, and it's one cut here, but you don't see any erosions in the bone. And so the bone looks pretty good there. And that's a really good opportunity to tell our medical oncology colleagues, if you can get this thing under control, this is a patient who's really likely to see benefit. I see a hand up.
If this patient was less than 18 years old, would you still try like compassionate use pexidartinib or luspatercept, or would you actually go with imatinib?
You guys want to?
That's a good question. I mean, there are, several centers in the United States that are looking at pexidartinib in pediatric populations, right? And they see wonderful efficacy of it as well. But imatinib is also a good drug, right? And we often don't see dramatic shrinkages with it, but you see tremendous symptomatic improvement. So you kind of have those informed discussions with patients. I will say, because one of the questions here is how do we use pexidartinib, right? And pexidartinib does have a REMS program, and it does require that you check blood work weekly for about 9 weeks, right? So you do watch things closely. But importantly, the majority of patients do really well with it. And when we design the studies, you have to remember we design studies in developing a phase 1 for oncological indications. And then we designed a clinical trial in which we were trying to hit a hard endpoint at 24 weeks with a poor outcome measure of RECIST. So patients started on really high doses of the drug and then they dropped down a little bit. But in clinical practice, you don't need to get a response in patients within 2 weeks, right? So oftentimes patients are started on lower amounts of the drug, do really well with it, and actually have tremendous improvement in symptoms. And that's, probably also that happens with the pediatric population as well. I know we're kind of running out of time, but there are some questions here that maybe we can get to, and one of them, Nick, maybe you can answer this. Talks about the extent of bony cartilage invasion. Does that affect PROs? And you were really instrumental in developing PROs, especially the Promise, right? So, do you think the way the Promise was developed, the joint destruction would affect the PRO?
Yeah, no, absolutely. And I think looking at this imaging, I think, it kind of came up in earlier in the discussion is not seeing those joint erosions makes me far more optimistic that medical therapy will have that dramatic improvement. I think all of us have talked about cases in which we actually get a good response to the tumor, but because of joint erosions and actually reducing that effusion in the knee joint, the patient comes in with a different set of symptoms. And they come in and say, well, now I'm walking more, but I'm getting more grinding in my knee because I used to have a blown up knee that was expanded. And now we've reduced the tumor. And so oftentimes there we're talking about, is there a combination type therapy? But here it's promising without those erosions.
Yeah, and interestingly, there's a question here about usage of pexidartinib, and I've said all the time in my clinic, our patients have told us how they should use the drug. So it's one of the few drugs that I will totally almost leave it up to patients to say how to use, right? Because again, this is a neoplastic process. Patients often have tremendous responses to therapy early on, and it's not something that, they need to take every day. So if they have a wedding to go to and take a week off, that's okay. If they are feeling too fatigued and they want to lower the dose for a little bit, that's okay. If they say, I'm going to take a little holiday because I have, this fatigue, that's okay, right? So you spend a lot of time talking with your patients, but you want to be able to incorporate these drugs in a way that works for their quality of life, right? And that's really important. And we don't know how long to use it, and it's variable when we stop it. But a lot of times, patients can have durable responses for long periods of time off drugs, so it is reasonable to stop. Um, and one last question, and this is more of a theoretical question. I'll throw this to Emanuela. And we're talking about having newer drugs come on the market. We're talking about antibodies and small molecule inhibitors, injectables. And I think it's a luxury to say we have options for our patients. But how would you think about sequencing all of that? If a patient comes to your office and you have all these options?
Yeah, I think this it is a very good question, and this case first illustrates that the sequence surgery and then relapse and then medical treatments is not always the case, and of course changing in between. different drugs requires a choice. So up to tonight in Europe, we don't have a single drug, and the United States there's only pexidartin. But I think in the future it will be interesting to seek based on, for example, age of the patient, family planning, how long the patient would be likely to treat intravenous versus oral, and short term continuous treatment. And the discussion is going to be, of course, based patient centered. But I think, of course, having all these options is really exciting and
Yeah.
much better for the for.
And again, I always tell my patients who are running a marathon, and the stupid analogy I use is, you may run with Nike shoes the whole time, but you may feel better with Asics, or you may feel better, right? So it's great to have options, and it may be that they want to try a drug and it really works for them. But if something comes back, they say, well, I really want an injectable. I don't want to take a pill all day. Well, we have that option, hopefully, right? So there are different things that, people can use to make sure you're not disrupting their quality of life as much as we often have to do in oncology, right? And I think this is one disease where we've been very excited to have, tremendous, tremendous collaborations to get a lot of these drugs hopefully out there to people, right? And so how we begin to manage it will be a very personal thing, but I do think the patient will know and will guide you, right? And they've done that throughout my career in this disease, so it's wonderful.
Before finishing, we have to conclude the case. So the
Yeah,
patient underwent Vexidart.
it's true.
A complete response. And I don't want to underscore that because we discussed with Roberto Viagini, an orthopedic from Rome, and he was like, "Give whatever you prefer, but is never gonna
Well, we
gonna
have more time, I'm getting.
gonna respond." And this is a complete response.
What are we doing on education? More physicians in rural areas that really don't know about it, orthopedics, even primary care. But I think the focus right now is on surgeons, like you did in your institute. What are we doing for that? Because I think the main thing for TGCT is education. A lot of people don't know what it is. It's not on a MCAT question, never heard of it in medical school or nursing schools. What are we doing to make it more aware, the doctors?
Um, I think it's a great question, and I think it's something very practically speaking, it's part of what we're doing here tonight and what we all believe in. I think there are some really tangible ways. First off, this type of education does take a while, but not as long as it used to. And I am amazed in our region how many sports docs, how many general orthopedic surgeons are now sending patients to me for this conversation, whereas that never happened a couple of years ago. And so the education is happening. We want it to happen more quickly. But, one thing that is just one of these great examples is every orthopedic surgery resident in the United States takes a test every year to make sure they're up to date with information. And the last 2 years, there have been questions about this CSF1 blockade. And so, it may take a little bit as their residents going out into practice, but I think it is an amazingly powerful tool. You will not find someone in training right now who does not know this story. And being aware of this story is really, really important in just kind of thinking this has to show up. Your eye can't see what your brain doesn't know. And so just knowing that there's this pathway and this disease out there is really powerful.
But I think there is hope because I have another story. 1 hour ago, I received an email, and it was a bariatric surgeon from Kazakhstan. And he was like, I heard there are CSF1R inhibitors. So I think the news is already spread everywhere.
I think they took those questions away because everybody was failing it.
Yeah, it's interesting, and we face this a lot in rare diseases. But I will tell you, first of all, biology brings awareness. Having a drug brings awareness, right? This was a disease when we were first challenged with making a clinical trial in 2015 in tenosynovial giant cell tumor that we as medical oncologists did not understand the disease. So we had to go to the orthopedic oncologist and really develop relationships to say, teach us about this. But more importantly, we went out into the patient community with the help of the pharmaceutical companies, with the help of the orthopedic oncologists, and said, tell us what you're going through, right? And so we had to educate ourselves about it. But one of the things that I will say, and I don't know if Sydney's here still, because the education is coming from TGCT support. And if one of the messages that you're saying is we have to educate physicians, nurses, people who are growing in their career, I think TGCT support can help with that because, as I said, this is a disease where my patients educate me about what they're going through and how to use the drug every day. And in fact, I just sit down and just listen and say, well, what are you going to teach me today? And it's been a tremendous journey, but I think definitely, Sydney, that's a message we need to think about, right? But, please grab a mic and talk about some of the things that TGCT support is doing for education because it's wonderful. And Sydney has a PhD, and so she's out there talking about science, but there's not a patient that comes probably into any one of our clinics that hasn't touched base with TGCT. Maybe we should get some of the, young physicians out there to talk to her as well. Um, any other questions from the audience?
Oh. Hi. Yeah, I think in general, the effort is a collaborative effort, and patients, there used to be this nuance that anyone wearing a white coat knew everything. And I think there's a shift, and I think that shift is positive. And I think any provider that's behind that shift, like all of you beautiful people, I think you can feel it in the room when you're a patient. So thank you, everybody, for participating
Yeah.
and being here, right?
Yeah. But it is challenging in rare diseases, right? How do you get the message out there for that? Look, I mean, last time I took the boards, I had to learn all of oncology, and I probably overthought the two sarcoma questions there, then got them wrong, right? But it's how do you allow for that level of education to disseminate? It's a tough thing in rare diseases, but it's a great question. Um, there is a question here about. Oh, God, sorry, please, yeah.
My question, sorry, it's the unpleasant question. If you get that rare side effect of the catastrophic liver injury, vanishing bile duct syndrome, do you have any thoughts, advice on how to treat it? Like, do you do steroids? How often do you check liver enzymes?
Yeah,
So-
it's really scary. I mean, I think it's exceedingly rare, first of all, but you really have to watch. And what you're really watching for is the elevation of the alk phos, right? That's really the critical thing. And if you start to see that coming up, first and foremost is stop drug. You can watch a little bit to see what's going to manifest, but I think very quickly it's get the hepatologist involved. Steroids can be, very good and something we advocate, but most of the time, if it's caught early, it does resolve, right? That's the key, but it can be very, very difficult to watch people go through that and having the support of the hepatologist, making sure, just to do anything supportive is important. But it's scary when you see it happens, but it's exceedingly rare. Yeah. Did steroids help or?
They were listed for liver transplants. The bilirubin was 30, and we were watching closely to start with, but eventually it did settle out on its own. But
Yeah.
they had like no bile ducts on their first biopsy, and it just
Yeah.
happened overnight. It was like crazy.
So it is, a term that I learned, through this process. It's a vanishing bile duct syndrome, right? But it's idiopathic, but exceedingly rare. But that's why watching is really important. Yeah. All right, and there was a question here about radiation. I am not a fan of it. I know it can be an effective treatment, but we talk about it with radiation doctors all the time, and I don't think it's something that should end up in our treatment discussions with patients, right? I think we have a lot of good modalities to treat people with. Um, So that's just my personal.
I totally agree. As a general rule at Risoli, we always say in between us and with the patient that for a benign tumor, giving the treatment that might cause a malignant tumor, it's just bad.
Yeah. And I heard a squeak in the back, and I imagine that was Sydney squeaking. So I'm sure patient advocates have thoughts about that as well. And I see Torsten in the room, and Torsten helped discover the genes that, is allowing us to be up here talking about all of this. So, thank you, Torsten. But I do appreciate you here. It's great just to kind of have the dialogue. I mean, there's a lot of facets of TGCT historically that have affected how we develop drugs and interact with our pharmaceutical colleagues who've been exceedingly helpful and critical in really bringing our understanding of this disease to a level where we can truly help people. We need that level of support. It's been just dramatic relationships with orthopedic oncologists who have taken on all different efforts in drug development, probably something they never thought that they would do, and are just as facile in speaking about medical management, and hopefully we're getting better in speaking about surgical management. But I think one day when the history of all of this comes out, it really has, really should shape how we look at other diseases, and not to just mention the strong relationships we have now with patients. And at the least, reminding us to sit and listen to a person as opposed to assuming you know what they need.
I'm going to throw one very not closing comment, but something we didn't touch on that often comes up just quickly in 30 seconds, which is we often get the question, do you still need a biopsy? These MRI, is it enough? Do you need a tissue diagnosis? And I think that you guys can nod in confirmation, and especially because my partner pathologist is in the audience here. We still need tissue in this. I at least at our place, nobody is considering any sort of treatment without tissue. And I just want to make sure, with all the discussion of hemosiderin weighting and MRIs and things, especially as awareness is spotty, to your question earlier about TGCT, radiologists are either, some are calling everything TGCT anytime there's synovial inflammation, and some are calling nothing TGCT. And I think even in great hands, we still are in a place where we need tissue to make the diagnosis.
Checking NGS and evaluate more tumors.
It's difficult because the majority of the tumor is not the neoplastic clone, right? So, it took a lot of our colleagues, understanding how to identify those cells to study. So NGS is usually not something that we would see, but there have been extensive, analyses of these tumors to understand them genomically.
I was diagnosed with TGCT in 2018.
Yeah.
I had many years of pain before that. And so nurse practitioner, I work with sarcoma, so that's what I do. So I just happened to fall in the sarcoma team and fell in love with it. And I love my team. It's the UM team. But it's amazing what you guys have done with this, because when I was diagnosed, it was never a talk about systemic therapy. It was straight to surgery. So that's why what you're doing in your institution is amazing. And I really thank you for that, because a lot of patients don't get that option. And I really appreciate everything you guys have done
Yeah.
for this disease.
Well, thank you. I mean, but again, it's such a collective effort, right? And our pharmaceutical colleagues who've allowed these drugs to get here, and stayed with pexidartinib, I think is really important, and then found ways to bring other drugs, through, and just a collaboration with the patient advocates, and so it's really been a communal sarcoma effort, and I think that's beautiful. And so I'll say thank you, but I'm going to give the last word to the boss, Emanuela,
Yes.
and see how you can send us home.
I will close thanking everybody for coming in tonight, and we remain available for any question online for all of you. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, TGCT Support, a program of the Life Raft Group. This activity is supported by independent educational grants from Daiichi Sankyo Incorporated and Deciphera Pharmaceuticals. To access all materials for this activity, visit peerview.com/UCG860.